Now we're going to switch gears a little bit and speak about or discuss ROS1 targeted therapies. And I'll be the speaker. I guess I can introduce myself. I'm an assistant professor at Harvard Medical School and attending physician in the Center for Thoracic Cancers and the Termeer Center of Targeted Therapies at Massachusetts General Hospital Cancer Center. Thank you everyone for joining us for this session one more time. Let me share my slides. So here's my title slide, and then here are my disclosures. So as many of you have heard from earlier sessions today, there are increasing number of oncogene drivers that we know about in lung cancer, which have really important implications on how we think about treatment options. For the next few minutes, we're focusing on ROS1, which is the oncogene driver that is identified in, I would say, 1 to 2% of all non-small cell lung cancer. ROS1 fusions or rearrangements were initially discovered in lung cancer now over a decade ago in 2007. And ROS1 fusions indicate that part of the ROS1 gene is abnormally joined or fused to part of another gene. So there are many different gene partners that have been identified for ROS1 in lung cancer. But what this is trying to show on the right is that in all of these ROS1 fusions, regardless of which gene serves as the partner, the ROS1 kinase domain is retained and is active. And that is really what ultimately causes the cancers to grow. Now, we know of certain features that are associated with ROS1 fusions in lung cancer. This was from a study published back in 2012, where 18 patients who were diagnosed with ROS1 positive lung cancer were evaluated, in addition to 31 patients with ALK positive lung cancer. And what this study showed is that patients who were diagnosed with ROS1 positive lung cancer tended to be younger at diagnosis with a median age of around 50, also tended to have minimal smoking history and have adenocarcinoma type of lung cancer. And these are really very reminiscent of what we had learned about ALK positive lung cancer at that time as well. In my mind, the key point here is that young patients or those who have minimally smoked can definitely get lung cancer, as can others. And so it is really important to test all patients, any and all patients who are newly diagnosed with lung cancer for these gene alterations. Specifically for ROS1 fusions, the testing can take the form of multiple different methods. To the left, FISH or fluorescence in situ hybridization was the earliest diagnostic method that was developed for ROS1 in lung cancer. And in this assay, there are two colored fluorescent probes, green and red, that bind to different parts of the ROS1 gene. So when there's a rearrangement involving ROS1, there's splitting of the green and red signals, or perhaps in some instances, isolated 3' red signal that can happen as well. In select centers, they also perform immunohistochemistry or IHC, which is really trying to stain for protein expression of ROS1. And then NGS or next generation sequencing is really an increasingly used and preferred diagnostic method, not only for ROS1 fusions, but other oncogene drivers in lung cancer, because of the huge advantage that it offers, which is that it allows for contemporaneous testing, multiplex testing for all of these different potentially actionable gene changes. So now let's focus on ROS1 targeted therapies. The standard initial therapy for any patient newly diagnosed with advanced ROS1 positive lung cancer will be a ROS1 tyrosine kinase inhibitor. At this time, there are 2 ROS1 inhibitors that are approved by the FDA for the treatment of ROS1 positive lung cancer, and these are Crizotinib and Entrectinib. Both are highly effective drugs, and I'm going to show you the key data here in the next few slides. Starting out with Crizotinib, Crizotinib was the earliest ROS1 inhibitor to be approved. This is actually a multi-targeted TKI that inhibits ROS1 in addition to ALK and MET. In fact, it was initially developed as a MET inhibitor and then first tested in ALK-positive lung cancer patients. And then when ROS1 fusions were discovered and validated in lung cancer, the phase 1, the ongoing phase 1 study, Profile 1001 of Crizotinib, was modified and amended to include an expansion cohort of patients with advanced ROS1 lung cancer. And so here, what I'm summarizing is at the top, the number of patients who were evaluated in this study with ROS1 positive lung cancer, and then what we call the objective response rate, which is the percent of patients who had tumor shrinkage that was deemed significant enough to be called a response in a clinical trial. And then the median progression-free survival, or PFS, which is the duration of time between a patient starting on the therapy and then the time that disease progression or deterioration was declared. And so here you can see that among 50 patients with advanced ROS1 positive lung cancer who received Crizotinib, the majority had received at least one prior line of treatment for their advanced lung cancer. And here the objective response rate was 72% with a median PFS around 19 months. And based on these results, Crizotinib was approved in multiple countries for advanced ROS1 positive lung cancer. This was back in 2016. And here are the representative scan images showing the types of response that you can see with Crizotinib or other ROS1 targeted therapies in a patient with ROS1 positive lung cancer. So here you're looking at computed tomography or CT scan images. And here on the left is the baseline image, meaning before the patient started on Crizotinib. And then to the right are the images showing tumor response as encircled by the red here after 6 weeks of treatment. These kinds of rapid and dramatic responses are not uncommon with these effective targeted therapies. Entrectinib, as I mentioned, is the other TKI that is approved for the treatment of ROS1 positive lung cancer. This is also a multi-targeted TKI. It has activity against ROS1, but also against TRK and some activity in ALK. So in an integrated analysis of 3 trials, at the time of the initial publication, there were 53 patients that had been looked at with ROS1 positive lung cancer. Here, the objective response rate was 77%, and the median PFS was 19 months. And so you may recall that these numbers appear similar to what was shown in the prior slide with Crizotinib. I would say one key difference to note is that entrectinib has shown more data, has been systematically evaluated in patients who have known brain metastasis and has shown good CNS efficacy in that setting. So that is an important observation to make here. I did want to mention that as a result of these ROS1 inhibitors, the median overall survival of patients with advanced ROS1 positive lung cancer is getting longer. So this was an updated analysis of the Profile 1001 Crizotinib data, where the median survival of patients who were treated with Crizotinib was around 51 months. And we're hoping that this can continue to improve over time. Another difference between Crizotinib and entrectinib is in the side effect profile. So recall that Crizotinib inhibits MET in addition to ROS1 and ALK, whereas entrectinib inhibits TRK. And so the side effect profiles do differ. So with Crizotinib, visual disturbance is common, especially having to do with dark to light adaptation. Also common are side effects like nausea, diarrhea, vomiting, edema. With entrectinib, the most common side effects include dizziness, dysgeusia, meaning change in taste, weight increase, burning, prickling sensation, and these are all thought to be related to the TRK inhibitory effects of entrectinib. So here in this table, I've summarized for you the ROS1 inhibitor landscape in what we call TKI naive or newly diagnosed advanced ROS1 positive lung cancer. Again, as indicated by the asterisk, Crizotinib and entrectinib are FDA approved with some differences in the relative CNS activity as well as the side effect profiles. The other drugs shown here have demonstrated activity in ROS1 positive lung cancer, however, are not approved for this indication. So just to briefly go over these, Crizotinib is what we call a second-generation ALK inhibitor, but this drug has also shown some activity against ROS1, as you can see. This was in a Korean phase 2 study where the response rate and the median PFS appeared comparable to what had been seen with Crizotinib and entrectinib. Again, this is not approved for ROS1 lung cancer. Taletrectinib is a drug that was initially evaluated in a small number of Japanese patients. And here, among patients who had newly diagnosed ROS1 positive lung cancer, the response rate was 67%. More recently, at the ASCO annual meeting this year, some of you may have seen this, the preliminary phase 2 results from China were presented, where among 15 patients who had crizotinib naive ROS1 positive lung cancer, the response rate was 93%. And then lorlatinib and repotrectinib have also been evaluated in ROS1 positive lung cancer. Both have shown quite encouraging data. So for lorlatinib, PFS is pretty comparable to what I had shown earlier for the other ROS1 inhibitors. One major advantage of lorlatinib is that it has very robust CNS activity. It is a highly CNS active drug. And then repotrectinib is a next generation ROS1 inhibitor that is currently in phase 2 testing at multiple centers internationally. And in a preliminary analysis among 22 patients who had TKI naive ROS1 positive lung cancer, the objective response rate was 91%. Median PFS has not yet been reported. I should also note here that with repotrectinib, among 3 patients who had measurable brain metastasis, all 3 had intracranial responses. So it does have some CNS activity as well. Certainly, cross-trial comparisons are difficult, and these are all pretty small numbers if you look to the right of the table. But I would say it is very exciting to have several inhibitors which have shown good clinical activity in advanced ROS1 positive lung cancer. And I think going forward, whether some of these next generation ROS1 inhibitors will prove superior to crizotinib or entrectinib in patients will remain to be determined. Now, how about after the initial therapy with crizotinib or entrectinib? What's the landscape of second-line ROS1 inhibitor options? So the options in this setting may include lorlatinib, repotrectinib, taletrectinib, all of which I have mentioned already, or cabozantinib. I will emphasize again that none of these agents are currently approved for this indication and remain investigational. And here, the key factors to consider in deciding which option may be best for a given patient would include what we see in terms of the duration of response to these drugs in the second-line setting, the level of CNS activity, and the spectrum of activity against different ROS1 kinase domain resistance mutations, for example, those that might confer resistance to crizotinib or entrectinib. So to that end, at Mass General, we've looked at a series of biopsies that were obtained from patients who were experiencing cancer progression on crizotinib. This was a series of 42 biopsies. And over a third of these biopsies were found to harbor a ROS1 resistance mutation or a new change in the ROS1 gene. And the most common ROS1 mutation detected in this setting was the G2032R mutation as shown here. This is important to note and remember going forward because several of the available ROS1 inhibitors actually do not have good activity against this mutation. All right, so starting out with lorlatinib. Lorlatinib is a next generation ALK and ROS1 inhibitor. You've already heard quite a bit about lorlatinib from Dr. Kim earlier in this session. Lorlatinib has shown some activity in patients with ROS1 positive lung cancer after crizotinib. So here, among 40 patients who had received prior crizotinib, the objective response rate with lorlatinib was 35%. Median PFS was 8.5 months. Notably, lorlatinib is far more brain active than crizotinib is, and attesting to that, the response rate against brain metastasis was 50%. So you might imagine that for patients who are experiencing cancer progression mainly in the brain as the active site of cancer, lorlatinib could be a very good option there. Repotrectinib is another next-generation ROS1 inhibitor, again, right now in phase 2 clinical trial testing. This drug has shown encouraging clinical activity in patients who've already been previously treated with other ROS1 inhibitors. Objective response rate after one prior ROS1 inhibitor was 39%. However, if you looked at specifically what's considered the recommended phase 2 dosing of the drug with crizotinib as the prior ROS1 inhibitor, in small number of patients, the response rate there was 57%. Of note, repotrectinib has shown activity in patients who are known to have a ROS1 G2032R resistance mutation that I mentioned earlier as the most common ROS1 mutation after crizotinib. So it's challenging to make right now comparisons between lorlatinib and repotrectinib, but I do think it's important to note three specific factors. First, that both drugs have shown activity against brain metastasis. Second, that repotrectinib has shown clinical activity against this ROS1 G2032R mutation. So if you have a genotyping result that shows a known ROS1 G2032R, that might make us favor repotrectinib. Third, side effect profiles between these two drugs differ and do matter. So lorlatinib side effects you've heard about from Dr. Kim, hyperlipidemia being most common, and some of these other side effects as shown here. With repotrectinib, the most common side effect that we see is dizziness. In most instances, this is mild and manageable. And then some of the other common side effects are listed here. And some of these side effects are thought to be TRK related because repotrectinib is also an effective TRK inhibitor as well. I also wanted to mention that at the ASCO meeting this year, again, Dr. Zhou and colleagues presented the preliminary data for taletrectinib from the phase 2 study in China, where they did report clinical activity in patients who had baseline G2032R mutation as well. So I think it's worth watching out for further updates from taletrectinib study. Another novel ROS1 inhibitor to watch out for that some of you may have heard about is NVL-520. This drug was previously called NUV-520, being developed by Nuvalent. NVL-520 is a highly selective and brain-penetrant ROS1 inhibitor, and it was specifically designed to be selective against TRK, which can cause some of the side effects associated with some of the available ROS1 inhibitors, as I mentioned earlier. And it was also developed to be potent against the ROS1 G2032R solvent front mutation. You can see here that the preclinical potency data is compelling against a range of ROS1 mutations. The drug was able to suppress tumor growth in non-small cell lung cancer PDX models, including one that was harboring a G2032R mutation. And then on the right is demonstration of intracranial activity of this drug in a mouse tumor model. So these data were presented at the AACR earlier this year, and the drug will enter phase 1 testing very soon at multiple centers, including Mass General. I wanted to briefly mention cabozantinib because some of you have heard about this drug in the context of ROS1 lung cancer. So cabozantinib is a bit of a different drug. It's really what we call a dirty, quote unquote, multi-kinase inhibitor because it inhibits many proteins, including ROS1, MET, RET, VEGFR, and others. So cabozantinib has shown clinical activity in crizotinib refractory ROS1 positive lung cancer, including in tumors with solvent front mutations. On the other hand, though, cabozantinib can be very challenging to tolerate. It's associated often with significant toxicities having to do with skin, the GI system, blood pressure issues, and others because of the multi-targeted activity. So I would say that in general, we rarely use cabozantinib in clinic and tend to favor the more selective ROS1 inhibitors. So what is our treatment approach to advanced ROS1 positive lung cancer? Increasingly, we're using this sequential therapy approach where the initial therapy may be with the approved drugs like crizotinib or entrectinib, followed then by a next generation ROS1 inhibitor, perhaps in a clinical trial, and then perhaps followed by other clinical trials, such as combination regimens or chemotherapy. And at each junction of therapy change, it's really important to consider what is causing the resistance to the prior therapies, what's the status of CNS disease, because that may also impact the treatment decision-making, what are the side effect profiles, and of course, logistically, what is the ease and speed of access to all of these different treatment options. And so to summarize, crizotinib and entrectinib are currently FDA approved for advanced ROS1 positive lung cancer and represent standard initial therapies. Next generation ROS1 inhibitors for second line use are available either off-label or in clinical trials. And going forward now, we need to better understand ROS1 independent resistance mechanisms and develop novel strategies to overcome these. But first and foremost, the starting step is to detect this potentially targetable gene alteration in addition to others. Thank you very much.